and the lead CNS here at UCH. So I've been organising it with help from Joanne and the team here. So same as last week, if you can make sure you don't record from your own screen because it will slow down Teams for everybody else. We are recording it so we can send it out along with the PDF of the slides if the speakers don't mind. Also today I will send you the evaluation. I didn't send it out last week, so I apologise. If you can just catch up with that for last week's session and this week's session. And then that, I think, is everything. Make sure you stay on mute. We are trying to keep everybody muted as they're dialing in. But if you drop off the call and come back in, you may not be. So if you can just make sure that you are muted at all times. You can ask questions. So Bernard is going to speak first, and he'll take questions after his presentation because he's got to go to do a ward round. So if you have a question, if you can just either type it in the comments box or raise your hand, and then after I'll come back to you and we'll go through your question, whichever you prefer. So if Bernard is ready, just take you off mute. Joanne, can you just unmute Bernard? Or Bernard, can you unmute yourself?
Can you hear me?
Lovely, yeah, perfect. We shall get started.
Okay, well, morning everyone. My name is Bernard Davis. I'm one of the hematology consultants at the Whittington Hospital. And my brief this morning is to talk in outline really about sickle cell disease. Of course, it's a very, very complex multi-system disease, and it's impossible to cover everything in one session. But I'll do my best to highlight some important points. And if you have any questions, then feel free to ask at the end of the session. So it's important to, first of all, think about what sickle cell disease is. And the first thing to say is this, that it's not one condition, it's actually a family of conditions in which the presence of an abnormal hemoglobin known as sickle hemoglobin causes pathology. So remember, it's a group of conditions, inherited conditions, and it results from a mutation in the gene that controls the production of beta globin. And the result of this mutation causes replacement of one amino acid, valine, for glutamic acid in position 6 of the globin chain. Now, this one substitution is really what underlies sickle cell hemoglobin. The problem with sickle cell hemoglobin is this, that unlike normal hemoglobin A, it can form chains called polymers under unfavorable conditions, and this will result in a distortion of the shape of the red cell to attain that sickle shape that we're also familiar with. Now, of course, there are many different types of sickle cell disease. As I said, it's a group of disorders, and basically it's when sickle hemoglobin interacts with itself or another abnormal hemoglobin or a thalassemia trait. But the three main forms that you're likely to come across in your day-to-day practice are what I've shown there. So the first one is sickle cell anemia, which is the homozygous form of the disease. It is also by far the commonest form, not just in the UK, but around the world. Now, what's interesting is this, that even though the patient has homozygous disease, not everyone will have the same level of disease severity. So you can have some people who have severe disease, such that if you don't intervene when they're little children, they can come to harm. On the other hand, you have others who have very, very mild disease, which hardly troubles them during the course of their lives. So it's very, very variable in its severity. The next important one is sickle hemoglobin C or SC disease, which accounts for most of the remaining causes of the disease. Now, you have to be careful about SC because there are many patients who go around thinking that SC means that they're sickle cell trait. SC is not sickle cell trait, it's a form of sickle cell disease. They tend to have a milder course, but SC can also be severe, in fact, sometimes as severe as SS. And then you have sickle beta thalassemia. This is when, again, you have sickle cell hemoglobin interacting with a beta thalassemia trait, and the result is not thalassemia, it is sickle cell disease. There are two main types here. One where they're not making any globin chains at all, called beta 0, S beta 0. Those tend to be as severe as SS, and then there's a milder version who have a milder clinical course. Now, worldwide, sickle is the single most important, I'll say, monogenic disorder. This is likely to be an underestimate, maybe around 300,000 births a year. You know, the vast majority of those happen in sub-Saharan Africa. And there also, unfortunately, it's estimated that quite a high proportion die before the age of 5. Here in the UK, sickle is the commonest genetic condition. The birth prevalence is about 1 in every 2,000 births, so roughly around 350 odd births a year. In total, again, no one really knows exactly how many patients, and in this country, the best estimate is maybe around about 14,000 patients, and most of them live, not surprisingly, in London. This is a map of the hemoglobin disorders in England and Wales. This is taken from the National Hemoglobinopathy Registry. And what it shows here, I don't know whether you can see it, it shows that London is a major hotspot, as indeed the Greater Manchester area. There are also, you know, high prevalence areas in the Midlands. But apart from that, you can see that large sections of the country are low prevalence areas. And it's important that we remember this because we still have patients who attend hospitals in those low prevalence areas. So it's important that care is provided to those patients as well. And these patients may be students who are studying in universities in those low prevalence areas. Now, just a quick run through of the pathophysiology of sickle cell disease. It's extremely complex. I've tried to simplify it quite a bit here. All I'll say for reason of time is this, that it starts off with the polymerization of sickle hemoglobin. That leads to, as we've said, the formation of these sickle red cells, which basically, because of the reduced ability to navigate their way through the small blood vessels, plus a host of other complex factors, results in vaso-occlusion. Vaso-occlusion has various consequences, including reperfusion injury. Sickle hemoglobin polymerization also causes hemolysis, and therefore sickle cell disease is a chronic hemolytic disease. Hemolysis, as well as other factors, result in endothelial injury. And the consequence of all of this is this, that these patients have ongoing inflammation, which of course feeds back into vaso-occlusion and reinforces the process. So it's extremely complex. One of the good things about this complexity is this, that it allows various points of this process to be targeted in terms of treatments. We mentioned the sickle shape. This is just blood films from 2 patients showing the kind of cells that we'll call sickle cells. So some of them are a bit more boat-shaped, but they're still sickle cells. And the clinical consequences would include things like vaso-occlusive crises, commonly known just as crises. And here you've got vaso-occlusion affecting the left humerus in this patient. And I don't know whether you can see it very well, but there's swelling, it's shiny and inflamed. So that's just an example of a vaso-occlusive crisis affecting a limb. But you can have other complications, including chronic complications such as avascular necrosis, which tends to affect the weight-bearing joints, the hips particularly, but it can also affect other joints, including the humeral heads. So this is avascular necrosis of the left femoral head in one of our patients who went on to have a total hip replacement at a young age. Other complications include things like leg ulceration. Sickle cell leg ulcers are very, very difficult to treat. They cause agonizing pain. They tend to be very, very difficult to heal. And I've just put this in here to show you some of the difficulties that these patients can have. And then the other chronic problems like sickle retinopathy, which can cause blindness. And we've seen that in some patients that we've looked after who sadly have become blind as a result of sickle cell disease. So it's a condition with widespread effects and no organ system is spared. Now, in recent times, we've kind of understood that the two broad subphenotypes of sickle cell disease. So you'd find that there'll be at one end some patients who tend to have the so-called vaso-occlusive phenotype. Now these ones tend to present a lot with pain, with things like acute chest syndrome, avascular necrosis, and so on. And then on the other side, you have people who predominantly have hemolysis and vascular damage. These people tend to present with things like stroke and pulmonary hypertension and so on. Now, of course, there's marked overlap between these two extremes, and patients will usually manifest characteristics of both phenotypes. Now, I put this here because these hemolysis group often tend to be forgotten because some of them have very little pain, but in fact, they also have they can have very severe disease and have a shortened lifespan. Down on the bottom here, I've put the fact that these patients are hyposplenic and so are susceptible to infection, and that as they grow older, they accumulate organ damage, and therefore you'd find that many of them will have, for example, poor renal reserve and easily run into acute kidney injury and so on. Now, whether they have the vaso-occlusive phenotype or the hemolysis phenotype, when they're very ill or when they're acutely ill, that is irrelevant. They behave more or less the same. And as we shall see, one of the features of this condition, sickle cell disease, regardless of genotype or phenotype, is how quickly they can become very, very sick. So just to give you an example, this is a patient who still comes, attends our service. This is a long time ago, actually, with classic features of acute chest syndrome with extensive bilateral shadowing here. And this was taken on ITU just before she was intubated. Now, she is still alive. In contrast to this patient who hardly had a crisis in his life, but then presented one time, this is some years ago, in severe right heart failure, even though he'd never had a crisis in his life. Sadly, he is no longer with us. I put us in just to illustrate that just because they have quiet disease and not frequent pain doesn't mean that they can't get very sick and have increased mortality. Now, Obviously, it's important to look after these patients very well. The talk will focus on 2 acute presentations, but it's just a quick run through of some models of care. Now, I've mentioned this as this kind of Pearson model because Howard Pearson is a physician in the States who came up with this idea, which still forms the basis of much of the care that we give to these patients, where you screen them at birth, pick them up and diagnose them early, enroll them, in infancy, around about 2 or 3 months of life, and be able to care for them from that point on. And I've highlighted this here, which is relevant even in adult patients, which is follow-up or care by what he described as knowledgeable and available staff. Now, this is really very important because a lot of the difficulties around the care of these patients, particularly adult patients, revolves around this particular thing or lack of it. And I'll come to that later. So what we aim to do, the idea is to link antenatal and newborn screening programs with effective clinical care. So here we try and prevent problems. So a lot of the care is largely preventative, educating the patient, try to get them to avoid precipitating factors. Sickle is interesting in that its cause or its behavior is hugely influenced by the psychosocial circumstances of the patient, and it's important to recognize that and to deal with those problems effectively and at an early stage before they take over the patient's life. Now, there'll be some patients with more severe disease who need some sort of intervention to modify the course of the disease, to ameliorate the severity of the disease. And again, we'll come to that in a moment. And then, of course, you have situations where, in spite of all the prevention strategy that you're adopting, patients still get problems, acute problems, chronic problems, which you need to treat. So sadly, we try very hard to encourage patients to self-manage their condition, to live healthily, not to be hospital-dependent patients. Now, sadly, some patients don't succeed, but the vast majority do live, very, very fulfilling, independent lives. And let me pause here by saying here is that in your practice, you come across patients who are frequently in hospital. Now, that group constitutes a very, very small minority of the patients. The vast majority of patients, maybe I'll say 90% of them, you probably won't really see. It probably be about 10% who present recurrently to hospital. And of course, what we're trying to do ultimately is to extend the patient's life. So what are some of the disease-modifying therapies that are available? Well, the first is hydroxycarbamide, also known as hydroxyurea. We won't go into that. We would usually use it first line to modify the disease. We know it's effective in reducing the incidence and frequency and severity of vaso-occlusive crises, acute chest syndrome, and mortality. Blood transfusions can also be used, and here you can use them electively in a long-term transfusion program, usually as an exchange transfusion. Again, we know that patients who were frequently in hospital, when they go onto blood transfusions, then hardly ever come back into hospital. It's important to be aware, though, of its long-term complications. Bone marrow transplantation is curative, and the best results are obtained when the patient has a fully matched sibling that is a match. I mentioned about new advances in treatment, all sorts of work. There's a profusion of work going on to look at various ways of managing sickle. just highlighting this new drug which came on the scene recently, crizanlizumab, approved in the States only last November. I don't think it's approved as yet in Europe and in the UK. Now, this drug works by blocking an adhesion protein called p-selectin, and it's been shown to reduce the incidence of sickle pain, regardless of the genotype of the patient. So it's a watch the space situation here. We'll be hearing more and more about this treatment. So what is it that it's important to know about sickle or about your interaction with a patient? Well, first of all, when you encounter a patient with sickle, you want to know a bit about their pain, where the pain is, how severe is it. Importantly also, it's always good to ask if the pain they're experiencing is the usual sickle pain. Now, it's very, very interesting that the patients are usually able to distinguish what is sickle pain from what is not sickle pain. Find out about any triggers for their pain. Think about their past history, very, very important. So if there are any features in the past history which indicate severe disease, such as previous severe complications, ITU admissions, whether they've been ventilated in the past, and so on, all those are important in helping you to understand how the disease has behaved in the past and how it's likely to behave now and in the future. Some patients that you look after may not be your own patients. They'll be patients that are treated elsewhere. And it's important when you come across these patients to find out where their base hospital is and who the primary consultant is. Now, this is really, really very important because if you don't contact the usual place of care, you miss a lot of information. So it's really very important to always contact the primary center where they're treated. Very important, especially when the patient is acutely ill. Now, bear in mind also that these patients will have so-called steady state values. These are values which they have when they're well and in between crises. So the hemoglobin will be at a certain level. Creatinine is usually lower than the normal reference limit. So if you see a patient with a normal creatinine, it's possible that they already have established renal impairment. I'll mention oxygen saturation. Bear in mind that these patients should normally have normal oxygen saturation. So if you see someone with a low oxygen saturation, then think carefully. That is not a normal situation, and it may represent the presence of underlying problems that you need to attend to. Now, just a few principles in the care of the acutely ill patients. Number one, vaso-occlusive crises are usually precipitated by problems that are unrelated to sickle cell. So it doesn't matter where they start off, nearly always they kind of end up sickling. Very, very important also that the painful crisis is, if you like, the gateway to life-threatening complications. So most of the life-threatening problems occur within the context of a painful crisis. Number three, these patients may be sicker than you might realize when you first look at them. So always have a high index of suspicion, okay? And keep a close watch on them. In all the years I've looked after these patients, I'm still amazed by how quickly they can go off. Very, very quickly. They can go off from being quite well 1 minute, and by the end of the day, they're intubated on ITU. Remember that the usual ways in which we determine inflammatory markers or inflammatory responses may be delayed. So your CRP may be normal when the patient is quite sick, only coming up later, maybe 24 hours later. And again, the usual things that we look at for escalating to ITU do not usually apply to these patients. So I would say that if the patient is becoming unwell escalate very quickly to the critical care team so they can move the patient to ITU or HDU if required. Just as an example, this is a patient, well, one of my patients still came in some time ago with a painful crisis, just an ordinary pain. SATs were 96% in room air in A&E. The chest x-ray was pristine. And within a matter of a few hours, he developed widespread shadowing. As you can see, SAT had dropped to 71% on room air, and he was in severe type 1 respiratory failure. So bear in mind that they can go off very, very, very quickly. These are just examples of some of the sickle syndromes that you'd come across. We don't really have time, so it's just to highlight that no organ is spared. This is just a selection of a few. Now, what we're going to do today is look at the vaso-occlusive crisis and acute chest syndrome, because these are the common ones that tend to present acutely. So let's go on to the painful crisis. Now, it's the most common presentation that you come across. And there are many things which can trigger a crisis. I've put them there. So things like infection, dehydration, exposure to cold or wet conditions, unaccustomed physical exertion. One of the most important triggers is stress. And as I said, stress from any cause can, by some unknown mechanism, trigger a crisis. But many of your patients will come in without any identifiable trigger. They just sickle for no apparent reason. Now, we tend to think of sickle crises as episodic, and with the patient being pain-free in between the episodes of acute pain. But the truth is this, that there'll be some patients who have continuous, almost daily pain, and it's important to be aware of that. Now, what are some of the features of the painful crisis? Well, first of all, the unpredictable events in terms of the onset, the location, and the severity, and also the duration. So in terms of location, usually multiple sites are affected, but the pain may be localized. The pain may flit from one site to another and vary from episode to episode. Now, I've mentioned this already. There is no one specific description of sickle pain, and every patient will describe their pain differently. What's important for you to recognize is this, that every patient, well, nearly every patient that I've looked after, is usually able to distinguish for themselves what is sickle pain from what is not sickle pain. So it's a very, very discriminatory and important question to ask. Is this pain like your usual sickle pain? And we've mentioned that the pain can last for a few days, but bear in mind that it can go on for much longer, for a couple of weeks or even longer. And frequently also the patient gets recurrences of pain within the same acute episode. And as healthcare professionals, we may not understand while the patient is having an extended admission, it's because they're having recurrences of the pain. So the patient is ready to go home, and then suddenly when you go to discharge them, they're in severe pain again. It's quite a feature of this condition. Again, this is a graph showing the distribution of the pain. The back seems to be, the lumbar spine here seems to be quite a common site, but any bone in the body can be affected. And interestingly also, abdominal pain tends to be a common feature of vaso-occlusive crises. I'll say always be careful about a patient, sickle cell patient with severe abdominal pain. Many times it's caused by sickling itself and should be distinguished from a surgical abdomen. This is just to show that the number of crises a year is an indicator of severity and it's related to mortality of the patient. So here, in adult patients, people who have had 3 or more admissions a year has a significant increase in mortality compared to those who have fewer episodes a year. So if a patient keeps coming back again, that's a bad prognostic sign. And just to give an example, this is a patient again that I, one of my patients, in fact, the patients whose chest x-ray we saw with acute chest syndrome. This is an old slide which I discovered when I was preparing this talk. Now, she came to us in 1997, just one admission. She stayed in hospital for 13 days. And you can see year on year, quite a steep increase in the number of days spent in hospital, so that within about 5 years, she was spending like over 100 days in hospital with up to 9 admissions in that year. So things can escalate very, very quickly if you don't manage them effectively. And again, it's important to recognize that people behave differently in response to pain. So in the center, they have put infarction, which is the result of vasocclusion, but the patient's pain behavior is influenced. This is my own thinking, really, and I'm sure others would have additional things or different things. It's influenced by the patient's, psychological status. So, for example, if the patient is depressed, they might respond to the pain differently. If the patient has difficult social circumstances, if they're homeless, the way they respond to the pain would be completely different from someone who is not in that position. There will also be cultural influences, I believe, in response to how the patient, responds to their pain. And sometimes, especially for those who have recently moved into the UK, this can be quite challenging because they may not be able to express themselves properly, and healthcare professionals might not understand why they're responding in that particular way. Sometimes people might think that they're being aggressive when all they're doing really is to try and explain that they're in severe pain. So keep these things in mind. So I'll say here, one of the most important messages is this, that when managing these patients is to have the right approach and the right attitude. Bear in mind that these patients have their own tricks that they use to manage their pain. Importantly, I'll say here, don't judge the patient's pain level by their behavior. This is one of the things that causes a lot of distress to patients, and we get a lot of complaints because of this. The patients will say, just because I'm sitting down quietly reading my book, it doesn't mean I'm not in pain. Or just because I've walked down to the shop to go and buy a drink, it doesn't mean I'm not in pain. So please don't think because they're behaving in a certain way, they can't be in pain. That's the wrong approach. And what I'll say here is this, that everyone, and I'm sure you'd agree, just want someone to be kind to them. And so whatever it is that we do, the transfusions or the medications and so on, the most important ingredient in their care, to me, is just kindness and compassion. And that's what the patients remember the most. So how do you manage a painful crisis in hospital? I know I'm going at a galloping rate. Well, number one is this: obviously, pain needs to be relieved promptly and effectively. And here again, let me emphasize this point because it's a cause of a lot of aggro and distress and unhappiness. Most patients manage their crisis at home. So when you see a patient in hospital with a painful crisis, nearly always it's because the usual strategies have not worked at home, and they're in hospital because they have to be there. Now, of course, there are 1 or 2 patients who unfortunately have difficult problems and may abuse the system, but don't tar everyone with the same brush. Most patients will come in because the pain is severe and they're not able to deal with it at home. That's why they're there. They're in hospital. And I've known or I've observed in the years of treating sickle that we tend to undertreat the pain because of concerns about opioid addiction. Now, that's actually not quite correct. That true addiction is rare. Some patients will be tolerant of opiates because they've been on them, but true addiction is rare. So don't, for fear of addiction or addiction concerns, deny the patient the pain relief that they need. And again, listen to the patient, believe what they say. If they say they're in pain, they're in pain. If they say they've got 8 out of 10 pain, they've got 8 out of 10 pain. We're not in a position to judge. Again, there'll be some patients who unfortunately try and abuse the system. These patients would usually be known to staff. Even those patients can get very, very sick. So always turn a new page and assess the patient objectively. Remember also that some of these patients may come in already taking strong painkillers at home for chronic pain. It's important to point out here that we used to use Entonox quite a lot in the past, but we don't any longer because it can damage the marrow and cause neurological damage as well because of B12 deficiency. I don't know about other ambulance services. The London Ambulance Service will usually give Entonox, but in hospital they shouldn't really have Entonox because it causes problems. It doesn't cause any problems when used for labor pain, but in the kind of frequency and duration for sickle crises, it does cause problems. We stopped using pethidine a long time ago because it can cause seizures in the doses that we use for treating of sickle pain. We've mentioned also already that if the patient's care is based elsewhere, it's important to contact the hospital and get the information on the patient so that you can manage them effectively. Really, really very important. Now, bear in mind that so-called hospital hoppers are a tiny minority. And certainly here within London, there is a system for identifying these patients and keeping track of them and managing them. But if a patient turns up in your hospital, don't think it's because they're evading their own hospitals. The patient may simply be in your hospital because they've been taken ill while visiting a relative or some other reason like that. Okay, PCA is the best, but bear in mind that some old school patients might not be enthusiastic about PCA, and I think it's reasonable to try and accommodate that tiny subset of patients. It's important, obviously, to keep a close watch on the sedation scores and so on. Bear in mind that some patients may require HDU or even ITU for management of their pain. Let me point out the importance of the patient key record, or the protocols as they're also known. Now, these are treatment plans that have been devised for the patients based on years of experience of looking after that patient. And usually what that key record does is to summarize not just what they need to control their pain effectively, but other comorbidities that they might have, which might have an impact on their care. So it's important to check those protocols. But remember also, again, this is another thing that we get complaints about. These are just a guide. I've known it before where a patient has come in, obviously in agonizing pain, where they've been denied effective pain relief because the protocol says that they should have, let's say, 10 milligram of morphine. And therefore, people are reluctant to escalate the dose simply because what it says on the protocol is not what the patient actually needs. So please use your judgment and give them what they need as per your assessment. And then the other things that we do, so fluids are important, antiemetics. I've put in here, some patients will ask you to give them intravenous cyclizine. Please don't. From my conversations with them, it seems as if some people get a buzz from IV cyclizine. We don't use it, and I'll strongly discourage anyone from using it. Okay, some patients, get really bad itching with opioids, and again, antipruritic agents are needed. Importantly, also, even with ordinary painful crisis, please look out for clinical deterioration and act quickly when that occurs. Going on very, very quickly, next 10 minutes to look at the acute chest syndrome. Now, this is a condition which can be lethal. Okay, it's a leading cause of death in sickle patients. Okay, and it's kind of difficult to define. A consensus definition is this: that it's an acute illness in which you have fever with or without respiratory symptoms and new shadowing on the chest X-ray. So that is the definition. The problem, though, is this: that the patient may be afebrile, in fact, frequently don't have a fever when they have acute chest syndrome. When you examine them, you may find that they don't have clinical signs, so the chest signs may be absent. If chest signs are there, they're usually crackles and so on. And you go and take an X-ray, and you may find that even though they have chest syndrome, the chest X-ray looks clear. And the reason is this: that the chest X-ray signs often lag behind the clinical signs by quite a long time. And so here, you need to have a strong, very, very high index of suspicion. And I think that anyone who becomes hypoxic, you should consider the possibility that they have this syndrome. Okay, these are some of the causes of the acute chest syndrome. So lung infection in about half the cases. There was a time when we will try to distinguish acute chest syndrome from pneumonia. We don't do that any longer because it's impossible to distinguish whether you're dealing with a pneumonia or with a chest syndrome. And therefore, we treat all suspected cases of pneumonia in sickle patients as acute chest syndrome. And then you can have episodes of fat embolism where globules of fat escape from necrosed marrow and embolize to the lung. You can have pulmonary infarction. You can have chest syndrome occurring if they've had too much opiates and they're drowsy, or if they're unable to take deep breaths because of pain in the chest or thoracic spine, and therefore they're splinting that side of the chest. Now, again, like other features, chest syndrome will usually occur during a painful crisis. We've mentioned some of the features, so I won't go over that. What I'll mention, though, is this: that in sickle patients, generally, if you're monitoring their oxygen saturation, it's best done when they're breathing room air. What I've and others have observed is this: that you can have significant hypoxia, which can be masked by just small quantities of oxygen. So the patient's sats are 95% on 1 liter of oxygen. You take the oxygen off and check it again, and the saturation is 82%. And therefore, the most sensitive way of monitoring the oxygen saturation, and I can't emphasize this enough, is to check that on room air. We do very, very simple investigations to try and diagnose acute chest syndrome, so usual blood count, biochemistry, ABG, and so on. Blood transfusion is important in the management of chest syndrome, and therefore it's important to get a cross-match sample, a group and save, or very early. Part of the problem also is this: that blood for sickle cell patients has to be specially ordered in from the National Blood Service, and therefore there's a time delay. So whenever you suspect this thing here, this syndrome, acute chest syndrome, it's important to send off a group and save or a cross match very, very early on. And of course, we talked about chest x-rays, and microbiology can also be important in looking after these patients. These patients will usually have raised inflammatory markers, even though I've pointed out that they may be delayed. They often become more anemic because of increased hemolysis. Be careful about people with low platelet counts or low normal platelet counts. This usually signifies people who are quite sick. So a low platelet count in the context of acute chest syndrome is quite a marker of a severe episode, which is associated with a high rate of ITU admission and ventilation. And we've seen this again, this will be your typical appearance. So generally speaking, in adults, it tends to involve the lower and middle lobes. So you have quite extensive shadowing here, bilateral shadowing. But bear in mind that unilateral shadowing, so this will also be a case of chest syndrome. Now, in the old days, we would say that this is pneumonia. We don't anymore. This is acute chest syndrome because they've got shadowing on that chest x-ray. So how do we treat chest syndrome? Well, we've mentioned blood transfusion. Most patients would need blood transfusion, but remember, not all patients will require blood transfusion. So some patients with milder conditions, you may be able to get away without a transfusion. And we'll give them a top-up if they've got a low enough HB to allow us to transfuse them. We try and increase their hemoglobin to around 100 grams per liter. We try not to go too high, otherwise they run into problems with hyperviscosity. If they've got severe disease or if they've got a high hemoglobin when they develop the syndrome, or if the chest syndrome progresses in spite of an initial top-up transfusion, then we'll exchange them. And usually transfusion is associated with quite rapid improvement in the patient's clinical status. It's important to give them effective pain relief, but don't oversedate them because then they don't breathe in properly, and then the situation can get worse. We use IV fluids here, and we'll give them antibiotics as we would for a severe community-acquired pneumonia. And because of the high incidence of atypical organisms or involvement by atypical organisms, you should always give them antibiotics to cover atypical organisms. Most patients will just need just oxygen and can be managed on the ward. Chest physio is really important. Always get chest physio for your patients. It makes a big difference. Would usually issue them with an incentive spirometer to use, but I think the input of a chest physiotherapist is also very important. Obviously, people with more severe disease who require higher levels of support need transfer to ITU for enhanced support, including mechanical ventilation and other organ support if they have evidence of multi-organ failure. So, in conclusion, rather than focus on all the wonderful pathophysiology and the pharmacological and other treatments, I think that this should be the take-home messages. Okay, when you're looking after these patients, it's really important that you always assess them properly, even for those who come in frequently. And we might think that these patients are frequent flyers, so to speak, because even for those patients, there'll be 1 or 2 occasions when they're really genuinely very sick. And so don't prejudge things. Always open a new page, assess them carefully, believe them, and manage their pain effectively. We've talked about being kind and compassionate. To me, that's what the patients remember the most. And we've talked about being maintaining vigilance at all times, because these patients can go off so quickly. It's unbelievable. And I'm going to stop there and ask if anyone has any questions.
Thank you, Bernard. Okay. I haven't had anybody have any questions, but I think somebody raised their hand, but I can't see that anymore. Was you? Can you just do it again? I think something that I always struggle with is the patients when it's chronic versus acute pain, and how they differentiate between that when they come into hospital with a flare up. It's really challenging. Really one of the bigger things.
Bernadette, sorry to interrupt, but there's a real reverb on the system.
Okay, I wonder why.
You haven't got your phone, put it on your phone.
No. Is that any better?
Yeah.
Wonder why it was doing that. But I was just saying that chronic versus acute pain, when they have a crisis and flares up, and find it personally quite difficult, quite challenging to manage, and trying to manage their expectations as well, in terms of okay, and you've got this chronic pain, you've come in with an acute crisis, but realistically you're still going to be in pain when you go home. I find it really challenging, because obviously we just want to make everybody better and get them to that point of discharge, but I know it's difficult.
Yeah, I agree. It's extremely difficult. It's really difficult. And there'll be some people with very complex chronic pain. And sometimes some patients will come in for treatment of the chronic pain. And it's very difficult to explain to them that, well, the treatment of that chronic pain is not with parenteral opiates in hospital. There are other things that can be tried at home. It can be very difficult, I have to say. I would say here, I remember as a junior doctor, how, such challenging situations, could easily exhaust, emotionally exhaust one in a space of like a week. So you go in, thinking you can solve things, but yeah, you can have very difficult clinical situations. I agree.
Thank you. So question from Linda about the new drug, and I can't say it at all.
Crizanlizumab.
Do we have any kind of idea of when it's going to be coming to the UK, and a bit more about how it works, if you can do it in a couple of minutes?
Yeah, well, I don't know when that will be licensed. Usually these things happen first of all in the States, and then so I'm just going to go back to show you the slide. It doesn't have many things on there. Okay, sorry, I've gone past it. So then it gets approved in Europe. Then of course here it's got to go through the various processes with NICE and so on. So it's I think that it's some time yet before it comes. So what it does here is this, that we've mentioned how it is that the vaso-occlusive process is extremely complex. And we know that it's not just, mechanical blockage of blood vessels by distorted, sickle cells, but actually you've got all sorts of things going on. So the sickle red cells, especially the younger ones, are abnormally adherent to vascular endothelium. And then you also have interactions between those cells and things like white cells and platelets. All of those play a part in the sickling process. So the role of adhesion molecules has been known for quite some time. Now, one of those adhesion molecules is this molecule called p-selectin. Okay, and so the idea is this, that if you're able to block its activity, then of course, then you can interrupt the process of vaso-occlusion. Interestingly, some of the earlier studies involve the use of heparin or heparin-like drugs, because heparin actually blocks p-selectin. But it's this drug, crizanlizumab, which has had, if you like, the first success with blocking p-selectin. And what it does is this, that by blocking this, you interrupt the vaso-occlusion process, and then the patient gets better. And so what in the trial, and this was published a couple of years ago, and only licensed last year, it's an IV infusion. You give it over 30 minutes. In the trial, what they did was they gave 2 loading doses, so day 1 and then 2 weeks later, and after that you need an infusion every month. And what they realized was that the frequency of the crises was significantly lower compared to the placebo arm. And it didn't really matter whether the patients were taking hydroxycarbamide or not. And it didn't also matter whether they had SS or SC or some other genotype. It worked across the board. This is unlike, for example, hydroxycarbamide, where the evidence really is for SS and S beta 0. But this one works across the board. So I don't know when it will be introduced, but I think that if and when that happens, that would be one extra thing that helps us to manage these patients.
That'd be good. Do you know if the trial was adults or children as well?
I think if I remember, it was adults. I need to go and check again, but I think it was in adults. I can't remember that children were involved.
Yeah.
I'll have to go and check.
Obviously. And there's a comment from Pauline just saying about Entonox. There's someone that attends her hospital regularly that has regular Entonox. I know here at UCH we don't do it past the ambulance, or maybe for a little while in A&E while they're waiting for their first dose.
Yeah, I mean, yes. Now the funny thing is that Entonox is a very, very effective. It's very effective painkiller, and for sickle pain as well. Now, what it does though, now Entonox is nitrous oxide, and it very rapidly inhibits vitamin B12. And you know that if you have B12 deficiency, you can have neurological complications as well as bone marrow toxicity. Only late last year, I got contacted by a GP about a non-sickle patient who had developed neurological symptoms because he was using Entonox recreationally. So, I mean, I'm sure people would know about Nox and so on. So it's become a popular recreational drug. But there are a number of things, quite apart from its effect. And I've known a patient now comes to mind who had subacute combined degeneration of the spinal cord, which is, quite a severe disability from overuse of Entonox following repeated use of Entonox in crises. And therefore, for that reason, I think that if they explain to the patient why that should not be used, they probably come around to it. I've also known it to be addictive. So we've had a couple of patients who have become addicted to it. I remember when I used to attend at UCH, having an issue with one of the patients who basically would climb, you couldn't get the Entonox away from him. So I think for those reasons, it's important not to use it, because when they become disabled because of that irreversible neurological toxicity, there's nothing anyone can do about it.
Yeah. Great. Thank you, Bernard. And the last one, they're curious about what happened to your patient that had the frequent hospital admissions. You know, you showed the graph of them attending more and more across the years.
Okay, so as I said, I dug that one out, I don't know, from the archives when I was preparing this. What happened is this, that you can see that that graph stopped at 2002, because when she had that chest syndrome, she ended up on ITU. Again, she was one of those quiet types. We only picked up on the chest syndrome because one of the consultants walked on the ward and spotted her in the corner, dangerously ill. She was ventilated for a week, and after that, she went on to hydroxycarbamide. She's now on exchange transfusions, and she's now about 55. Now, this happened like 18 years ago, that episode. When she turned 50, she couldn't believe it, you know, and yeah, she still comes to our clinic. But what it shows is that with proper care, you know, patients can live long, healthy, very fulfilling lives, you know. When she had that chest syndrome, she had quite extensive lung damage and needed home oxygen for about a year. And we thought she's just going to need oxygen for the rest of her life. But she was able to come off oxygen, and then she was able to, you know, she spends time traveling around the world and so on. So yeah, things can change quite markedly these patients.
Story then.
Yeah.
That's great. Thank you, Bernard. That was brilliant. If there's any more questions, you can leave them and then I can answer them via email, because Bernard needs to head off for a ward round. So we'll let you go. That's great. Thank you, Bernard.
Thank you all. Thank you for listening to me.
Thank
you.
Thank you.
And next we've got Dr. Andrea Lee. She's a paediatric consultant with a special interest in haematology and oncology. So just give us a couple of minutes to swap over the screens and we'll be with you. I think, Bernard, if you log out the call or stop sharing your screen, Andrea will be able to take over.
Hi, everybody. I'll just get set up.
While Andrea's doing that, I want everybody to kind of think about some myths and stigma that you've heard in relation to sickle cell and people with sickle cell, just to have those in the back of your head and see if we can change some of those or answer some of those for ourselves and go forward.
I'm just waiting for permission to share my screen.
Joanne, can you see that?
Can you see my screen or no?
No, not yet. Strange. It worked earlier.
Did? Have you given me permission, Joanne?
I don't think she had to do it before, did she?
No, you can't see my talk, no?
No. You just... Oh, what happened? Joanne? Is it giving you the option? It's just saying you need the permission.
It just, yeah, it's coming up now. Got it.
Lovely.
Okay, now can you see?
Yeah, perfect.
Okay. Sorry everybody for that slight delay.
If you just try and click to the next slide, because last week they couldn't get it to work. Yeah, perfect.
Yeah. Okay.
Thanks.
Hi everybody. Sorry for that slight delay. I'm Andrea Lee. I'm a paediatric consultant working at UCLH, and I work with Sarah Trumpeter in the Red Cell Clinic and Bernadette there. So Sarah and I complement each other quite nicely because I'm a general paediatrician with an interest in blood disorders and oncology, and Sarah is a paediatric hematologist. So it's quite a nice way of working to sort of cover all bases in terms of looking after children. What I wasn't too sure what Bernard was going to cover, so I've got various options, and I'm really happy to take questions at any time. So please do type any questions into the chat, and Bernadette, feel free to interject if people have got pressing questions. So I was going to talk a little bit about sickle cell disease and how it affects children, particularly highlight some of the differences and challenges around managing children, because obviously no child is taken in isolation. There's a whole family and holistic context. There's the additional complexity of dealing with a condition, dealing with parental feelings, dealing with the stigma of a condition that is still very stigmatized in many communities, and also education and roles outside of the family. And that's before we even get to adolescence, where young people are learning to take control of their lives and their condition, and how we think about that. I think that we'll probably have a talk later on in the series when we Bernadette about transition and the importance of good transition and adolescent care within sickle cell particularly. But today I was going to run through a bit about the different conditions and the different complications that we see, how we manage children, how they come into our service, what are the key things that we do to try and maintain health as much as we can and well-being. I've done a little bit about hydroxycarbamide because there's been a relatively recent change to national guidance, which has meant that we're using much more hydroxycarbamide even for asymptomatic children. So it's can be helpful to understand a bit about that as well. As Bernard mentioned, he's done a bit about the background of sickle cell disease. It is the commonest single gene mutation disorder in the UK now, and within our clinic we have around 100 children with red cell disorders. As Bernard was alluding to, there's a variety and a spectrum of disorder, and you can't quite tell from the genotype always exactly how children are going to behave and what they may or may not have in terms of complications. Many children within our clinics have very, very few complications through childhood, and then there's the other end of the spectrum where we'll have some that have complications and are quite severely affected from early on in childhood. I think that we're getting better about being proactive in terms of management, and there are certain sort of mutations that go together to give sickle cell disease. So sickle cell anemia, as Bernard was saying, is if you've got SS, but you can inherit one sickle gene with a variety of other genes to give sickle cell disease. The main ones that we see within our clinic are if it's co-inherited, either with sickle or with a beta thalassemia. Now, beta naught thalassemia, I'm not going to assume anything about the audience, so please forgive me if I'm making it too simple or if it's too complex. Do let me know, or if there's any questions, please interrupt. So the beta 0 and beta plus thalassemia is whether you can produce any or no normal beta globin chains. Hemoglobin SC, as Bernard was saying, is often considered the mild form of sickle cell, and certainly in childhood that generally bears out. If you've got SC sickle cell disease, we tend to see far fewer complications, but that's not to say they can't happen, and particularly in times of stress, so times of infection, around surgery, things like that. Then there are other forms that can also be quite severe, and hemoglobin D Punjab with sickle can produce quite a severe phenotype as well. So this is really where the gene abnormalities come from and the global distribution. So you might recognize there, so the sickle gene is protected because when you have sickle cell trait, it's protective against severe malaria. Now, people often get confused, and our patients often do, to think that if they've got sickle cell disease, they are protected against malaria. And so it's really important that we dispel that myth and make sure that our families know if they're going to travel to malaria endemic regions, they still need to take malaria prevention and prophylaxis. As you can see from this chart on the left, the thalassemia genes tend to cluster around the Mediterranean, the Middle East, and into the Indian subcontinent. But we do see sickle cell from India as well. Side, this shows where there's high incidence of sickle cell disease. So care of children is obviously different to care of adults in many ways and similar in many ways. Most of the children that come to our clinic are detected on the newborn screening. And I don't know how many of the audience work within pediatrics or within adult services, but I think even if you're working in adult services, it's helpful to get a flavour of what these individuals have been through. And you have to remember that one of the challenges in terms of appreciating some of the psychosocial challenges around managing sickle cell disease is that these are essentially children who have never been free from disease. So if you contrast that to, a child who has treatment for cancer or a child who has diabetes, they're likely to have had a period of their life without this affecting them. But when you're born with sickle cell disease and you're picked up either antenatally or from your Guthrie blood spot, which is taken on day 5 of life, it's all you've ever known. And so everything, what the adults bring to you is an amalgamation of all of their lifetime's experiences, like all of us. And I think it's really helpful, even if you're working in the adult world, to understand a bit about what's childhood like for many of these individuals. So the blood spot is taken by the midwife usually on day 5 of life, and it goes off to a centralized testing center. The results are fed out, and if you are sickle trait, as you know, you get the card, and if you have a sickle disease, then that's informed to your local thalassemia and sickle cell service. Those services then have responsibility for informing the families, and via the newborn screening and the link to there's a portal that links to the sickle cell centres directly, and electronic referrals are sort of created. Now, the national standards and the standards for the care of sickle cell disease in children, the link is there on the website, and obviously we're happy to share these slides with you so you can look at them after. So by 3 months of age, the baby should have been seen by a consultant with expertise in hemoglobin disorders. They should be on penicillin V prophylaxis twice daily, and we usually add in folic acid. And they should have been seen in a clinic so that they know the local care pathways. So we discuss some of the complications, we explain our service, how and where to get help and when to get help. So what are the red flags? How might they know if there's a problem with their baby? Because obviously that can be very challenging. And we see them regularly in clinic. Now, it's a lot of information to receive, and we sometimes have to do that in dribs and drabs. And we like to keep a really close eye on little ones when we're first getting to know them and the family, and for them to get to know and understand about the condition. From 2 years of age, we start Doppler ultrasound screening, which is for risk of stroke. Now, the national standards are that is done if you've got sickle cell anemia, so HBSS, or if you've got sickle beta 0 thalassemia, because those are the groups with the highest risk of having a stroke in childhood. And we'll talk a bit about that in a while. Now, the importance of getting under appropriate care early on cannot be sort of overestimated. The reason for implementing newborn screening is that without the penicillin prophylaxis, without additional immunizations, and without good acute care for complications, these children really do have a significant risk of dying from sepsis. So from early infections, the risk of dying from sepsis in childhood, in early childhood, is significant anyway. It's one of the commonest causes of death in healthy children, and it's a significant cause in sickle cell disease. And the other thing that we do early on that improves mortality and reduces death from splenic sequestration is that we teach parents to feel the spleen. So we teach them in clinic where the spleen is, what it feels like, and it's difficult for families because there's usually not any enlargement of the spleen. And so what we're actually showing them and teaching them is, what does normal feel like, so that they know if it feels different to that, then they know to come and seek help. So we also recommend additional immunizations, and as per the Green Book, children with sickle cell are considered asplenic. So within early childhood, due to microsickling in the spleen stops working. And that makes these children particularly vulnerable to bacterial infections with encapsulated bacteria, which are particularly pneumococcus, meningococcus, and Haemophilus. So the extra immunizations are also really key and life-saving. And then we provide general advice as well. As children and young people grow up and through to adolescence, obviously there's more about emerging self-care, self-management, education, and changing needs, about sexual health, and all of the multitude of things that are relevant, and bearing in mind that it is clearly a genetic and inherited condition, and so it's important that young people are informed so that they can make the decisions and the choices that they want to about their lifestyle. So how are we doing, and what does it look like if you're born with sickle cell now? Well, it's a much better it's a much better time to be born with sickle cell, with emerging new treatments, with the potential curative options of bone marrow transplantation and gene therapies that are emerging. Back in the 70s, there was really a pretty poor life expectancy. And as you can see, as we've developed implemented the newborn screening, penicillin prophylaxis, extra immunizations, and along with screening for stroke, we know that if we find a child who has a high risk of stroke through screening, if we give them regular blood transfusions, we can reduce the risk of them having a stroke by over 90%. And so the risk of stroke in childhood has come down enormously from around 11% to now being around 1% with screening and transfusions. So this is just the latest data with some of the data from Northeast London, who have a very large sickle cell population, showing that the mortality now with best care is around 1%. So it's not insignificant, but it's better than it was through childhood. And the risk of stroke is now around 1% in childhood. I'm not sure how much of this is of interest and relevance to you, but I think this is helpful to see and understand a bit about the transition for babies. So this graph on the left shows which globin chains are produced when they're in the womb. So this is in utero, and you can see not many beta globin chains being produced, but the gamma globin and the alpha. So alpha globin and beta globin and gamma globin go together to make fetal hemoglobin. So at birth, the predominant hemoglobin is fetal hemoglobin. And the reason that we often say, or people are often told, that actually we see relatively few complications with sickle in the first 6 to 9 months, and often in the first year of life, because there's still a lot of fetal hemoglobin around. And as you can see here, as the beta globin chains increase after birth, these would be normal beta globin, but if you've got sickle, this is when you start producing your sickle hemoglobin. And so you're relatively protected by fetal hemoglobin in the first, up to the first 6 to 9 months of life. On the right is just a little drawing of how the newborn screening works. And this is high performance liquid chromatography. And this detects, there's a list of significant hemoglobin disorders that it will detect. It won't pick up everything, or it won't report everything as a significant finding. But what it does is it aims to detect significant hemoglobin disorders by detecting an abnormal hemoglobin or a significantly low hemoglobin A. So if you've got less than 1.5% of adult hemoglobin, it suggests you've got a problem with your beta globin. And here you can see this, you get these spikes. So if you've got a spike in the S position, then you've got sickle hemoglobin. If you have a spike in the C, then you've got hemoglobin C, etc. So I suppose this question was to try and stimulate a bit of chat, and Bernard's obviously talked quite a lot about acute chest syndrome and some of the complications we see. I thought it would be helpful to think about what we see in children at different ages and how they present a bit as well. So it might be helpful just to see in the group chat if on Teams, has anybody seen any complications with children? If you just type them in if you've seen any children with complications. Okay, so Bernadette's had a hard time seeing somebody have a stroke. It's unusual these days, but we did used to see quite a lot of stroke. And dactylitis. So yeah, does anybody know what dactylitis is? I'm sure you do. Oh dear, that must have been a busy evening exchanging twin brothers at 6. Poor things. Sequestration, Lucy says, yeah, so where do you tend to sequester? Yeah, so you can sequester in the spleen or the liver. And actually, one of the issues with sequestration is that you can sickle and lose and pool large volumes of blood into your liver and spleen, and they can enlarge significantly. And you can actually become hypovolemic and develop hypovolemic shock. We'll talk a bit about that in a while. Yeah. So dactylitis, yeah, common under 2. So it used to be quite frequent that was how children would present as toddlers with dactylitis. So sickling in the fingers and toes can be very painful, swollen, can lead to damage to the growing bones. So it's important to to treat aggressively. Aplastic crisis with parvovirus, yeah. That's the classic sort of textbook cause for a red cell aplasia. And these twins, parents very upset, wanted to know about bone marrow transplant, but related donors is a very complicated issue. Yes, it is. And if you've got affected twins, that must be even more complicated. How do you approach that? That's a minefield, I'm sure. Okay. So I'm going to go back to sharing my screen if I can. Has that come back? Are you seeing my screen now?
Yeah.
Yeah. Okay, perfect. So we heard quite a bit about vaso-occlusive painful episodes from Bernard, and I will just touch on how that's how that impacts differently on children and families. So cerebral, so stroke, silent infarcts. So silent cerebral infarcts are, we'll talk about stroke in childhood in a little bit, because it is unusual. You know, we rarely see strokes in children without underlying conditions, and so it's very unusual for us to see stroke in a child. Acute chest syndrome, so chest, again, Bernard touched on, people often ask me, how can I tell the difference between a child who's just got a normal chest infection, you know, viral induced wheeze or all the other things that children get versus acute chest syndrome. And I think one of the key, I mean, the key message is, you know, by definition, if you've got chest signs and a chest x-ray changes, you've got acute chest syndrome. In practical terms, for me, children don't get pain with chest infections generally, unless you've got a big nasty empyema and a chest drain. They might splint a little bit, but you know, with sickle, it tends to be very painful, with a t-shirt distribution of pain. So it might feel like it's sternal, might be the ribs, might just not be able to deep breathe, and it might not feel like it's sickling in the chest per se. It might be difficult to explain. It might be shoulder, girdle area, but essentially if you've got pain and any chest symptoms in sickle cell, then you have to flag that as acute chest syndrome. And so I always say to the juniors, if we've got somebody with pain and chest signs or symptoms, then label it as acute chest syndrome, because it just makes people aware that they've got a propensity to deteriorate extremely quickly, and then they need to be reviewed very regularly, make sure that we're really on top of the pain management, etc., to enable either for mobilization, incentive spirometry, and things like that. So talked about splenic and liver sequestration, infections, aplastic events. Priapism we do see in children. It is commoner in adolescents, but I've certainly seen 5-6-year-olds who have recurrent priapism. The retinopathy and retinal detachment is far less commonly seen in children, and we don't screen routinely anymore with yearly ophthalmology, but we do advise families that if children and adolescents particularly report any change in their vision, then they must treat that as an emergency, let us know, and get assessed and have a visual assessment. In terms of when does this happen for children, so as we said, risk of sepsis and invasive bacterial infections really early on in life. It never really goes away, as you know, but it's significantly high in children, and that's reflective of the fact that young children are at risk of infections anyway. Pain can be highly variable. Acute chest syndrome, again, often increases throughout childhood. Sort of early childhood is a significant risk, and sequestration, particularly in early childhood. My experience of acute sequestration is that often, so the textbook is that you have an increase in the size of your liver or spleen by 2 centimeters or more, with a corresponding drop in hemoglobin by 20 grams per deciliter or more. It's painful, tender, etc. My experience of sequestration is that it can be quite insidious and is not necessarily painful and tender. Once it's happened once, they have a propensity to just sort of re-sequester. So it's not uncommon to have children or young people where they've had a sequestration where their spleen may be not palpable normally or a couple of centimeters, and then it suddenly increases to 5 or 6 centimeters. They may need transfusing. It may take a little while to go down. By that I mean, you know, a week or two. May or may not go back down to baseline, but then that it can happen again. And if you've had more than one sequestration, then really we want to think about removing your spleen, because it's not working functionally anyway. And if it is if you are having sequestration, it is a real risk. And so we can see that, and we can see that older in childhood as well. So thinking a bit about pain and vaso-occlusion, so Bernard talked about it quite a lot. I think this is the thing that often parents, you know, when we see little ones and we're meeting families, there's often, this is the perception that they are going to have a baby, particularly if they've got SS. They're going to have a baby, a child who's in agony all the time, that it's going to be a terrible quality of life. And this can be really, really upsetting for parents. So, yes, I'm sure that you can imagine. And so part of our job is to help explain that actually, you know, our clinic's full of lots of children that have really good quality of life and have very few painful episodes. We can't always predict who's going to have a severe phenotype in terms of pain, but that we are certainly very active and proactive about reducing the risk. One of those changes is to offer, and in fact we encourage use of hydroxycarbamide before children start having problems, so from 9 months of age, and we can talk a bit about the guidance in a while. So this is a very complex relationship between sickle cell and pain and the pathology. But then if you add into the fact that there's also a parent who is caring for a baby or a child, you have these added complexities, then siblings who may or may not also have sickle cell disorders. There may be family history. So they may have family back home in Africa, for example, who have had a very poor experience or died very young with sickle cell. And all of these things will be brought with them to clinics, and it can be a very difficult diagnosis for lots of families to get their heads around. So one thing that I think and would really reiterate, as Bernard was saying, is that nothing is more important, I think, for these kids and families than the kindness and understanding a bit about what they're going through. So just these pictures I think are really helpful, because I think we can recognize that this picture, this guy looks like he's having a heart attack. Yeah, everybody looks at that and goes, oh my God, he's in pain, something's wrong there. So he's having a myocardial infarction. So his blood vessels have been blocked and have cut off the blood supply to his heart, and he's got infarctive pain. This woman down here, so she's in labor, she's having contractions. So when the uterus contracts, it cuts off the blood supply to the womb, and that causes infarctive pain. And I don't know about the audience, about who has been in severe pain. I've been in this category, and I found it really terrifying. I didn't know when it was going to come, although I had a pretty good idea because I had some dates. I didn't know when it did come how bad it was going to get. I didn't know how long it was going to last, and I never knew until it was over when you'd reached the worst of it. Luckily, when it was over, I knew that it was going to take some pretty hard work and quite a long time before it was going to happen to me again. And if anybody in the audience has ever been in severe pain, I think that those things are really terrifying, those feelings of not knowing when it's going to come, how long it's going to last, how bad it's going to be, what you might miss because it could strike at any time. You know, whether that's your school prom, whether that's your brother's birthday party, whether it's a family holiday, whatever it is, you don't know. And so I think that this slide is really about thinking about, so these two, everybody would say severe pain. But what about these guys? And what about this guy here? You know, he's smiling, he's sitting up in bed, he's gaming, he's got a buddy or a sibling who's come to join him. You know, people might look at them and say they're not in severe pain. But I ask you to consider that painful episodes in sickle cell are infarctive. You've got loss of the blood supply, oxygen's cut off, you have potentially a significant size of infarction of bone and tissues. Then you get a massive inflammatory response. You know, we've all seen children who can put their CRP up to 200 or more from vaso-occlusive sickling. And that just gives you an indicator of the degree of inflammation and what's going on in their bodies. And yet they might still be able to employ the tactics and techniques that they've had to train themselves to use. So, you know, when you see children who are able to distract themselves by going to the playroom or by gaming or by doing something in bed, that doesn't mean that they're not in pain or in agony. They largely, the last thing they want on earth is to be in hospital. And if they are, it's because they really can't cope anymore with what they've had at home. And so, again, I ask you, when you see children and you see parents, imagine what that must feel like as a parent to have a child going through that. And you also know, you don't know when it's going to stop. You don't know when it's going to peak. You don't know when it's going to be better. You don't know what they're going to miss. You don't know whether they're going to survive, actually. And to carry all of that every day of your life is enormous. And so when you see these children, I ask you, please see this guy, see this woman, and recognize what it takes for them to be able to contain themselves.
I would just say, that pregnant lady, or the lady in labour in the picture, you know, I've spoken to a lot of my older ladies, and they said they would rather have a baby every day of the week, be in labour, than have a sickle cell crisis. So, you know, for those of you that have had children and found it awful, imagine doing it every day rather than have a sickle cell crisis. It amazed me that.
Yeah, I've heard so many times that women say having a baby is nothing compared to the pain of a sickle episode, and it's hard to fathom. It really is. And then to think that a child who, you know, how can a 5-year-old or a 6-year-old have the emotional understanding to be able to process that? Yeah. So we might be used to making assessments of pain in adults, but it's obviously different in children. So I don't know if we've got any paediatric nursing colleagues or medical colleagues on the call, but I'm just so what sort of tools do you know of, Bernadette? What I'm going to do is I'm not going to stop sharing my screen, but if anybody puts up anything on the chat, would you just call it out to me?
Yeah, will do. I'll read it out. Someone's already commented that the visual message is really effective when you're talking about conveying the message about judging pain. So that was really, the pictures that you put up really helped get that message across.
Yeah, thank you. I think it's something that I when I do this talk face to face, particularly with my nursing colleagues, I think it's really striking, and with the junior doctors, because I think it really hits home that what we assume we know about children with sickle cell, we have to dispel, and we have to forget all of that, and we have to relearn it, and we have to reframe it. And it really helps to be kind and to be generous when you hold that in your mind, because it's difficult for all of us, you know, to keep that kindness and that compassion.
Yeah. So George has commented about faces or visual analog scales and FLAC. I don't know what FLAC is, so I'll let you. Oh, look, there it is.
Perfect. So that was right. So FLAC can be used for babies. So from about the age of 2 months to 7 years, or even if they're any age, if they're non-verbal or unable to communicate. And so this score can be used based on behaviours and activities, basically. And then for an older child, we can either use a verbal pain score. So at UCH now with EPIC, our electronic system, we've moved to 1 to 4, which actually I don't like at all because I think it's very blunt. It is kind of no pain, mild, moderate, severe. I suppose it's helpful in some settings, but I think for sickle it can be not that helpful. Some of our patients find that pain scores really irritating. So generally I tend to ask people, particularly the teenagers. So we have one who gets very annoyed when people ask pain scores, because she says people ask a pain score and then they say, are you sure? Are you sure it's that? As though they don't believe her. And that can be very frustrating. It's also very blunt, I think. You know, there's a difference between my pain score is 7 and my pain score is 7. The worst it was when I came in was 8, but I still wasn't really able to sleep because every time I rolled over, I woke up with pain, and I woke up screaming. You know, so it's
very closed, isn't it?
Yeah, people like it because it's good for studies, and it's good for, you know, for electronic records, or, you know, a Pew score and things like that. It's like it's clean, but I don't always think it's that helpful.
Donna's also said drawings 9 for all ages, and a pain diary for 6 and over.
Yeah, brilliant. Exactly, and description is much more helpful, actually, isn't it? So what are they able to do? What's it interfering with? What's been sort of given and done that's helped? Observed behaviour is really important. We all know that if somebody is completely rigid in bed in agony, and they've moved to a phase of the episode whereby they can ambulate and walk around and take their PCA to the toilet and things, then that's a change in the behaviour that's likely to represent an improvement in the sickling. How that person interprets that response to pain, you know, we have to remember that pain is a response to a stimulus, and that response is influenced by loads of different things. So this is the Wong Baker pain scale, and that is also quite helpful, can be used from the age of 3. And then this is, so we talked about this earlier. So this is a picture of dactylitis. You can see red, slightly shiny, swollen hand, sausage digits. You can see they're a bit tense and swollen, the fingers. And as I said, this is often how little ones used to present before we had screening. So how do we treat this in children in real terms? Well, we're very lucky at UCLH in that we've got excellent play specialty support, and that's really, really key. There may or may not be things that help for families and for children. You know, massage, they may like to be massaged, they may want to be left alone, they might like heat, they might not. You know, hot water bottle, can think about TENS and relaxation techniques and all sorts of things like that. In terms of drugs, we start with the simple analgesics. We move up to codeine or dihydrocodeine. So in children, you're not allowed to prescribe codeine in under 12-year-olds because there were a series of events of children having hypoventilation and serious events after codeine, and the MHRA, the Medicines Regulation Authority, just banned it, which was a bit of a shame for us because we do find it quite helpful in a proportion of children. The way we get around that is by using dihydrocodeine, not in babies under 1, not in infants, but between the age of 1 and 12. And I would always be cautious about that. So I would not use it in children that have obstructive sleep apnea, because some of the children that died or had events after codeine had so after adenotonsillectomy. So if they've got sort of any signs of obstructed airway, I wouldn't use codeine. When they come in acutely to A&E, we use intranasal diamorphine, which works really quickly. Comes on in a few minutes, but it goes away. The effect goes away very quickly as well after about 20 minutes. So we always give Oromorph at the same time. So if you've got severe pain needing intranasal diamorphine, we would always give Oromorph. The Oromorph will kick in around 20 minutes, which is when the diamorphine starts to wear off, and the Oromorph should last for an hour or 2. We have quite good dose intensity of oral morphine, and the protocol, which we have adapted from the Barts Health East London protocol, we will give a dose on arrival, at 1 hour, at 3 hours, at 6 hours if needed. And we actually find that if you give good high dose oral opiates, you can usually get on top of painful episodes without having to go to PCA, but you do have to be not frightened of giving good high doses of oral opiates. Once you've got to having had about 3 or 4 doses of Oromorph, then we add in the long-acting oral morphine, MST. There are some alternatives. We can sometimes we'll use oxycodone, but most of our children are opiate naive and those that are that do come in with frequent episodes needing opiates, the morphine tends to work well. If we're not able to control things, despite good dose intensity of oral opiates, then we would go to an intravenous PCA or NCA, depending on their age. And we tend to go for morphine as our first option. We can use fentanyl, so particularly if they've got like an abdominal girdle syndrome, where you want to avoid worsening constipation, or if they get very symptomatic with side effects from morphine, we can think about fentanyl, or for acute chest syndrome, because it doesn't cause so much hypoventilation. And some of the older teenagers, particularly, we do use oxycodone as well. So for children, the key thing.
Andrea,
yeah.
Sorry, just while we were on that, somebody has asked if anybody's got any experience using any heat pads or wheat bags. They're struggling to find things to use at their trust. Obviously, hot water bottles are no longer in favour. So if anybody's got any comments about what they use in their trust, if you just type it in the messages, and then I'll keep track and let you know after.
So we have a few patients who bring their own, microwave ones.
The wheat ones.
Yeah.
Yeah.
But yeah, it's difficult because you can't. You're not, strictly speaking, you're not allowed to fill up gloves with warm water, are you?
No. Someone else has said that they use plug-in heat pads, gel packs that can be heated. It's just about what your trust will let you use, or what you can sneak in, I guess.
Yeah. Okay, so in terms of general management, so we've moved away from hyperhydration and we aim for full maintenance. So in children, for those who are not paediatric people, we do it based on your kilograms. So work out a maintenance fluids depending on your size. We'd always prefer that to be orally. We've moved away from hyperhydrating because it was obviously implemented because dehydration being a risk for sickling. So unless you're clinically dehydrated, in which case obviously we would rehydrate as per a standard pediatric rehydration, we would just aim for maintenance. And that's also because if you have fluid overload, it's a risk factor for PRES, which is posterior reversible encephalopathy syndrome, which is a sort of reversible neurological syndrome that we can see. And that is typically in the context of having a high blood pressure, maybe related to fluid overload, etc. So we aim for neutral balance, oral maintenance whenever possible. We treat the children as immune suppressed due to the hyposplenism. So in practical terms, we treat that a bit like an oncology patient. So it used to be, so if they have 2 temperatures over 38 or 1 over 38.5, we would have a very low threshold to start IV antibiotics. So our sort of broad spectrum ceftriaxone sepsis cover. We use oxygen only if they're desaturated. So as Bernard was saying, one of the key indicators for impending chest syndrome is a drop in your oxygen saturation. So what we don't want is people being on oxygen for comfort, or when they don't need it, because what you'll do is you'll miss that subtle drop. So, a child who normally has SATs of 96 drops their SATs to 92, 93. Now, in a normal child admitted with a problem, you wouldn't really mind about that. But actually, if you've got sickle cell, that's a real flag that there's something going on. They're either hyperventilating because of pain or what have you, and they're at significant risk of acute chest syndrome, or they've got acute chest syndrome. So we aim to keep people analgesic as much as possible to maintain mobilization. So we want them up and about, walking around. Incentive spirometry. So if you haven't seen this, I'm sure most people have. Ideally, we want children to be able to do 5 to 10 breaths an hour during the day when they're awake, and opportunistically at night. And the idea is you take deep breaths in, all the way in and all the way out, and it sucks the balls up, and you get you reach different levels that have little smiley faces, and that's the incentive, is that they get the smiley face. And the other thing is as Bernard was saying, that a vaso-occlusive painful episode is a significant risk factor for acute chest syndrome, and typically occurs, a few days into a vaso-occlusive painful episode. So you have to be mindful of that.
Do you ever give oxygen just for comfort? Somebody's asked.
No, I'm very, very clear with families. Some of the older teenagers still like oxygen for comfort. And because obviously because we say that times of deoxygenation causes sickling, worsens the sickling. But that's there's nice guidance that you shouldn't use it unless the SATs are less than 95. And personally, on a clinical level, and from understanding and appreciating some of the challenges of a pediatric ward, so training pediatric nurses, training pediatric junior doctors that change every few months, how to spot the signs of acute chest syndrome. For me, hypoxia and changes in oxygen saturations are such a critical indicator that a warning that something's going wrong with the chest. That for me, I take it off people. So if they don't need it, I make sure that they know and explain to the patients and the families, actually, it's a treatment. It's supposed to be prescribed. It's only for use if you're hypoxic for this very, very good reason.
Yeah, thank you.
So I might whiz through this a bit more quickly, actually, because Bernard talks quite a lot about acute chest syndrome and showed some chest x-rays. This is just an indicator to show that how quickly children can progress as well. So on the right-hand side, just the unilateral signs, again, pain, developing hypoxia. And this was within 24 hours. And she went to ITU and had an exchange transfusion and was ventilated. So we talked a bit about acute chest syndrome with Bernard. It's similar, actually, in children to adults. And as you're probably all aware, that one of the definitive treatment is transfusion, either top up or exchange. For those that haven't seen an automated exchange transfusion, you can see it's got a line in here, a line in here. And one of the things about the automated exchange is that it uses a lot of blood. You have to have decent venous access. Obviously, you can't have a really low hemoglobin to begin with, so you might need topping up first. I'm going to move on to talk a bit about cerebral complications, because it is quite an important part of the paediatric sort of screening and complications. And it is an issue that we do see in lots of children. Now, not many, as I said, have overt stroke anymore due to screening. But what we do see is we see this large vessel disease. You can get the endothelial damage and intimal thickening, and then you get stenosis, narrowing and stenosis of the blood vessels in the supplying the brain. You can get development of new blood vessels around. We call that moya. And if children have got moya, then they've got a really significant risk of stroke. Previous to Doppler ultrasound screening and transfusions, there was a significant risk of stroke in childhood in sickle cell anemia, so SS and S beta naught thalassemia. The way that we do Doppler scanning is it's obviously painless ultrasound, and you can either do it so imaging scan, where they actually they have a screen like a normal ultrasound, and they can see the blood flow using Doppler. They can check where they're measuring the blood flow velocity. Or you can have non-imaging, where you have the Doppler probe. You're not seeing what you're doing, but you're seeing the blood flow and across the blood vessel. Now, what we do is we measure the blood flow and the maximum speed, the maximum velocity. And if you've got increased velocity and turbulence, it suggests that there's a narrowing before that. And then the blood flow is all turbulent and increased. And the higher the blood flow, essentially the worse. it is in that we have a normal range, then we have a conditional range, where and then you have an abnormal range. And if the flow is above 200, you've got an increased risk of having a stroke. And that risk is around 30 to 40% risk of having a stroke within the next 3 years after that abnormal result. Now, what we often see is children progressing. They may progress from normal to conditional to abnormal. We know that there's more emerging evidence about the role of hydroxycarbamide, and that hydroxycarbamide may stabilize Dopplers and reduce, so if you've got conditional Dopplers, that may stabilize them and stop them progressing. We know that if you have abnormal Dopplers and we start regular blood transfusions, usually we can top up, and we aim to suppress the sickle percent to below 30%. We hope to see the Dopplers normalizing, and that massively reduces the risk of having a stroke. Interestingly, there's a whole cohort, and it's very common for children to have evidence of subclinical damage to their brain. And there was a recent study looking at school-age children, so on entry to school, with MRI, looking for evidence of damage we call silent cerebral infarcts. And a significant proportion of children do have silent cerebral infarcts. So up to a third of children with SS, sickle cell anemia, will have evidence of silent infarcts by school entry age. And although they're called silent infarcts because they haven't had stroke-like or TIA-like features clinically, they do impact. So you do have issues with neurocognitive impairment, with learning, and so they are important to know about and important to support these children. The risk of stroke peaks, has an early peak, so we do see it in young children. And I think this is one of the real drivers for the change in hydroxycarbamide use, because we're really keen to try and prevent this very early organ damage for children. So this is just a picture where you can see, so this is the drawing of how the blood vessels connect in the base of the brain, and then they supply the brain, the middle cerebral artery, the anterior cerebral artery, and the posterior cerebral artery, and they come out and, as you can see, supply the brain. And here you can see on this one, on this side, there's a real narrowing of the right anterior cerebral artery. Yeah, and there's stenosis in here as well. I am very mindful of the time. I've got people. Do you want me to carry on for a few minutes, Bernadette?
Yeah, I think so, and people can.
We're okay, I suppose.
Go if they want to, and because we're recording it, so they can watch it later if they missed the last bit.
Okay, fabulous.
And if you've got any questions, if you need to sign out but you've got a question, just put it in the comments, and we'll ask it, and you can watch back the video later.
So stroke can be infarctive, where you get blocking from these narrow and stenotic blood vessels, or it can be hemorrhagic, where you bleed. You can bleed into an infarct afterwards. In children, it's much commoner to have the infarct type of stroke. And you can see here, there's been a massive amount of damage there in the territory of the middle cerebral artery. So we would provide supportive care as needed, so neuroprotective supportive care if needed. We want to get some neuroimaging, because not all neurological symptoms are a stroke, but any neurological symptoms in a child should be considered a stroke until proven otherwise. They generally need an urgent exchange transfusion. If that's going to be delayed by more than a few hours, then, and you've got room to, i.e. the hemoglobin's not too high, you may well give a top-up transfusion. When you can and want stabilized, you're probably going to want to do an MRI and MRA of the head and neck to look at the blood vessels. And then you're going to need to think about secondary prevention. So one of the key things to preventing stroke is that if you've had a first stroke, there's a significant risk of having another stroke. So without transfusions, you've got a 50% recurrence rate of stroke. Even if you're well transfused with a hemoglobin % less than 30, you've still got around a 20% risk of having a second stroke if you've had a first stroke. So it's really the primary stroke prevention that is critical for these children. So we've talked quite a bit about infections actually, and talked about why we give the prophylactic antibiotics and prevention with immunizations. Not to forget the viruses, so blood-borne viruses and hepatitis B is now part of the routine primary immunizations for children, but also annual influenza immunization is also key. Thinking about abdominal complications, so as Bernard was alluding to, you know, you can get sickling in the abdominal vessels, and you can have sort of straightforward abdominal sickling if you like, but it can progress to this syndrome called the girdle syndrome, where you've got significant sickling in the mesenteric arteries. You get a very tense, very tender distended abdomen, but exquisitely tender and painful. You know, you infarct a lot of the bowel potentially. You get an ileus type picture, so reduced or absent bowel sounds, not passing winds, not opening bowels. Very, very painful, often needs PCA and fairly high doses of opiates, may well need exchange transfusion, and do need careful surgical consideration. And of course, children with sickle cell, like other hemolytic conditions, are at increased risk of gallstones and cholecystitis. But they're children, so they can also get anything else. You know, they can get urine infections, they can get appendicitis, all sorts of things. We talked a bit about splenic and liver sequestration already. I'm going quite quickly now, I'm aware, but please do put any questions or comments up on the chat, and Bernadette, feel free to interject. Aplastic crisis, somebody mentioned that they had seen. So the classic finding, you know, a child comes in to A&E and is significantly anemic. You know, they may have dropped their hemoglobin to 40 or 50. The second question after what's the hemoglobin is what's the retic count. The reticulocytes, as you know, are the sort of young red cells, and when you have hemolytic conditions where in sickle cell, you know, normally your red cells last and circulate for around 120 days, but in sickle cell, they circulate for a much shorter period of time before being broken down, maybe 30 or 40 days. And because of that, your body is producing many more red cells, so you have a high reticulocyte count. So for any hemolytic condition, how high your retic count is gives you an idea of the hemolytic sort of rate. In sickle cell, you should have a high reticulocyte count. So if you're anemic and you've got essentially a normal or a low retic count, then aplasia has got to be there in the differentials. If that happens, it's useful to send parvovirus. You can either do that acutely with a PCR, but the blood PCR is less sensitive than bone marrow PCR, and we don't tend to do bone marrow PCR. So whilst it's helpful to send a parvovirus PCR, it's also helpful to send an IgM and IgG for parvovirus. And one of the things to warn people, obviously, is if there are other children or other people in the house with sickle cell, then they need to have their bloods checked, because they may well have been exposed to parvovirus as well, if anyone's having chemotherapy or if anyone is pregnant, because it can cause hydrops fetalis in pregnancy due to fetal anemia. We tend to transfuse if you've got an aplastic crisis, if you're symptomatic or significant anemia. As you're probably aware, for transfusions in sickle, there aren't really any hard and fast rules. But you have to remember, if you've got no reticulocytes, you're not going to be generating and growing and developing any new red blood cells for the next sort of week to 20 days. And so if you've got low retics and anemia, you might be slightly nudged towards transfusing rather than waiting and see. Priapism, as I said, it is seen in children. Priapism is a prolonged and painful erection. You can either have a stuttering priapism where it's coming and going, or a fulminant where it's lasted more than 3 hours. People say that in sickle cell you don't tend to get such so much of the permanent damage with priapism, but I think that's a myth, really. I think you still have to, you can get damage, and you have to be, you still have to be very active, and you have to be seeking it, particularly in children and particularly in adolescent boys, because as I'm sure you can imagine, it's not necessarily the sort of thing that boys, young boys, children would maybe comment on. Maybe they would say their bits hurt, but may not be picked up on by families as such a thing. And adolescent boys may be embarrassed to tell anyone. So when we're seeing adolescent boys, it's really important in clinic that we speak to them on their own, and also that we speak to them with their family members to try and break down some of the barriers around talking about priapism. So talk to them on their own, ask about it, tell them about it, explain why it's important to find someone, to identify someone in the house or an adult that they could tell, or that they know our contact numbers so that they can contact us, and that they, we appreciate it's might be an embarrassing thing to talk about, but that it's really important that they do, because we don't want them to run into trouble. Again, it tends to be cared for in collaboration with the urologists, because they might need intracavernosal injections or shunting, but with hematology, because they might need exchange transfusions. We do use, there are medications you can use as well. And I think that is a sort of whiz through about most of what we see in childhood, and how we have an approach to managing. One of the differences between children and adults, I guess, is use of therapies and changes in guidance for hydroxycarbamide, but also the bone marrow transplantation, the gene therapies and experimental treatments that are emerging. They often obviously come later to children than adults to check the safety profile in adults before, and that means that often children are the latest to miss out to sort of benefit from novel therapies. Hydroxycarbamide, just to talk about quickly, is a drug treatment that there was a change to national guidance a couple of years ago. And in America, you're probably aware that most children with sickle cell, and in many states in America, it's a routine, a standard of care that babies are started on hydroxycarbamide and children are on it throughout childhood. It increases your fetal hemoglobin, but it also has lots of activities that we don't quite understand necessarily. It reduces the red cell adhesion molecule expression. One of the toxicities is also potentially one of the benefits, which is that it reduces your white count and your platelets, so it makes you less sticky, so to speak. There is a reduction in painful episodes, acute chest syndrome, Doppler velocities. There is emerging evidence about impact on long-term organ protection. So it's hoped that using hydroxycarbamide early may protect against the longer-term complications, such as chronic renal disease. We don't know about the pulmonary vasculature and the cardiac complications in adulthood. But what we hope is that by keeping children healthy and by reducing sickling from very early on, we know, as I've just said, that there's a significant chance of silent cerebral infarct. So if you imagine all of that micro-sickling, all of the endothelial damage that's going on, that's already set in childhood, that by the time you get to adulthood, where you've had 20, 30, 40 years of this ongoing inflammation and damage, then you can see why there's such a range of chronic and complex complications. And the hope really being that if we can get in as early as possible, we can reduce those risks. So the national guidance is that we should be offering, and the wording is important. The wording is not recommending, it's offering. And the reason for that is that there are toxicities related to hydroxycarbamide, not just the bone marrow toxicities, but queries about fertility and the impact on fertility, bearing in mind that what we're doing is we have proxy consent from parents But there are some people have concerns about the fact that young people may get to adulthood, may or may not have toxicity issues, and actually it wasn't them that consented, it was their parents that consented for treatment for them. So we have to be mindful of these complexities when we're treating children, that actually the parents are giving proxy consent. So the guidance is for SS and S beta naught thalassemia, so those with the most severe phenotypes and most risk of stroke, etc. We should offer hydroxycarbamide from between the ages of 9 months and 4 years to asymptomatic children. So get them before they have any symptoms. For older children, we should still offer and discuss the risks and benefits. And the benefits do include improved mortality. Clearly, if somebody's on hydroxycarbamide, we want them to stay on it. So it's not that we say you should be on it from 9 months to 4 years and then stop. What we're aiming for is to keep people on it and to hope to have the most benefit throughout. There may be some GI disturbance as a side effect, but I have to say I incredibly rarely see that in children. It's generally very well tolerated. Bone marrow suppression, we do say. What I tend to see is those that get bone marrow suppression also seem to get very good both clinical and hematological response to the lower doses. So it just suggests that they're very sensitive to the drug, but it works well and may well work well in lower doses in them. The increased skin and nail pigmentation is something that can really bother people, actually. So darkening of the skin and darkening of the nails. And I've had some children and parents that have discontinued hydroxycarbamide because of that. There are risks of potential teratogenicity. So for adolescents, we have to warn them that they should use barrier contraception and let us know if they're thinking of getting pregnant or do get pregnant. And there's slightly unknown impact on fertility. I know they're doing a study in America at the moment. So because there's such a big cohort of young adults that have been on hydroxycarbamide for a long time, this data will emerge hopefully. The men and boys do get a reduction in their sperm count when they're on hydroxycarbamide, but the feeling is that it returns when you stop. The impact on female fertility is less clear. But of course, if you've got terrible sickle cell disease, and then that may well impact on your fertility as well. And so it's slightly unknown at the moment, but we have to warn consent, and we have to keep consenting and making sure that people, as they grow older, children and adolescents, are aware of this. The standards are that you start on a per kilo dose for children, and we increase up to the maximum dose, which is 35 milligrams per kilogram per day, or the maximum tolerated. So say they become neutropenic at a set dose, we would not escalate beyond that dose. That would be their maximum tolerated dose. It does take quite a lot of frequent blood testing, and it does take frequent clinic visits and things. But equally, we hope that it keeps people out of hospital, we hope that it keeps them healthy, and we hope that it keeps them living longer and better. So it's been a kind of a whiz through paediatric sickle cell. In summary, it's relatively common in London, but it's not everywhere, obviously. That it must be really seen as a really complex multi-system inflammatory condition, has a multitude of acute and chronic complications and a real psychosocial complexity. I really hope and expect that we will be able to cure it during sickle cell during my career. Yeah, and it's been a pleasure to talk with you. It's always slightly unusual doing these one-way talks. So I'm just going to leave with what questions do you have?
That's great, thank you, Andrea. Had a couple of people just asking about how do you deal with the families who are reluctant, and you kind of touched on it. And I think from my perspective, it's all about revisiting. We introduce them to other patients and families that are already using it. providing with the evidence. Obviously, we can't guarantee that they're not going to have fertility issues or they're not going to have X, Y, Z side effect. But just revisit it and educate and keep re-educating, and hopefully they come round to your way of thinking. But I think definitely introducing to other families that are already using it is a really good way of hopefully combating any fears.
Yeah. And it depends on the family, doesn't it? Because there are some families that I give the guidance to. So I actually give them the BSH paper.
Yeah.
There'll be some families who can digest and understand that, and it's very clear in black and white that it improves mortality. And I think a lot of parents are swayed by that. I think with the fertility, so one thing to say is that we should be offering sperm banking and cryopreservation for adolescent boys. So for any adolescent boys who are able to produce a sample. And obviously that's a conversation that you must have away from families, because having lots of experience of doing that with cancer, mums will always assume that their teenage boys are not able to massively produce a sample. And so actually you need to have that conversation away from the parents and give them the opportunity to try and sperm bank. I think I think it's just we of course we have some families that just don't go for it at all and just don't want it. I think that they've often got quite fixed beliefs and worries about it that might be historic, whether it's reports about cancer, it causing cancer, or fertility is a worry for people. And I think we try and say, the sperm count for boys does go down, but it usually recovers, and also none of us know our potential fertility until we have children, and actually that being terribly sick and sickling around your testes or your vas deferens or wherever is going to be harmful probably to fertility as well. And actually, improving your life chances of being in school, being educated, transitioning well, engaging with care, staying well and staying healthy is going to improve your life chances so much that that all of that comes together.
That's great. Somebody commented earlier on, I can't remember who it was, about cultural taboos, and I guess this is the myths as well. So an African family were told that mum passed on sickle cell through breastfeeding, so then she didn't breastfeed any further children, and there was this whole big taboo around it all, and we still see it sadly in a lot of African families, predominantly I think. They didn't get it from me, and that kind of attitude. Hopefully it's getting better here, but I'm not sure what's happening in Africa. I'm sure it's still the same.
I think that also something that I've heard quite a lot is that we don't have sickle cell back home.
Yeah.
And one of the challenges around that is that probably many of the children that die from pneumonia or malaria have probably got sickle and are dying from sickle. And that actually, the children don't survive they don't survive beyond infancy or the first few years of life. And so that can be very difficult. I think it's challenging. But we have, it's not unusual to have families who have a mum who won't tell anyone in the family that their child is affected with sickle cell. And I think that must just be such a hard place to be, for that mum and that child with that.
And last question then. So is there any relationship between hydroxycarbamide and AVN? And would you stop it if they developed AVN? Do you see AVN in children very often?
Yes, we can do actually. So it tends to be shoulder girdle or hips. So any child that's got really prolonged painful episodes around the shoulder girdle, hip girdle, we would be thinking about looking for AVN. And yeah, certainly, you know, the teenagers do tend to have longer painful episodes, but if it was going on beyond weeks, or they've come back to clinic and they've still got pain around the hips or shoulders or somewhere, then I would be looking for AVN. That's an interesting one about hydroxycarbamide and AVN, because I know that some centres feel that there is an increased incidence of AVN with since they've been using high dose hydroxy, but I haven't seen it reported. I haven't seen it presented anywhere. I know that in East London, Paul Telfer was looking at it, and we had a case of a 8 or 9 year old at Whipps Cross, and we were talking about hydroxycarbamide and AVN. With a child with AVN established, I would be tempted to put them on a transfusion program and try and reverse that AVN and prevent progression, because otherwise, I mean, they're looking to having hip replacements, etc., aren't they, in early adulthood? And so I think whether you continue or discontinue hydroxycarbamide is probably a bit of an MDT discussion, depending on what you're going to do. But I would definitely make sure that they're getting some disease modifying treatment. And with my patient in Whipps, we decided to put her on transfusions. She was also had a severe phenotype, had splenectomy for recurrent splenic sequestration, had come off transfusions post-splenectomy and gone on to hydroxy, and had a lot of frequent painful episodes, and actually did much better on blood transfusions. And we were hoping to halt progression and recover her AVN, really.
Great, thank you. I'll echo you again. Don't know why. So we should probably finish now because we've run over. Thank you very much, Andrea. It was brilliant. So everybody, we'll send the videos of the talk and the presentations as well with the evaluation today or tomorrow. If you can just do your evaluation as you go along, so it's fresh in your mind, and then you don't need to send it in until the end of the 6 weeks. But thank you very much, Andrea, and see everybody next week.
Thanks, everyone.
Bye.
Bye.